Hey guys, Woodruff here. So we're going to go through some respiratory practice questions. And the purpose of a video like this is to, obviously, we're going to look over some content and stuff in these questions, but it's also to get into some strategies and start to look at what we could do to approach these tests in a different way, because sometimes, we can have all the knowledge in the world, but if we don't have the right strategies or we're not looking or reading the questions correctly, it's hard to be successful. So let's go to the first question, or let's attempt to and let technology fail me. All right, so the first question says, a nurse is assessing a client for acute respiratory distress syndrome. Which of the following assessments is most indicative of an early sign of ARDS? So I always like to reread the question first. I know a lot of you guys are going to say, like, I don't have time to do that in tests. I ran out of time. So while you're practicing questions, it's great to practice this skill. So that way, the more that you practice it, the better you'll be when you're on the actual exam. So it's good to practice reading and practice some of those things that you're going to do. But probably one of the most important ways to spend your time is making sure you know what the question's asking you. So I'm doing an assessment and I need to figure out which one is most indicative of an early sign of ARDS. So there's a couple things. I'm looking at an ARDS patient, looking at something that is a hallmark sign or something that's very common, and not just in any part of ARDS, in early ARDS. So I'm thinking of what is going to be one of the first things that they're going to show. So the first one I have is an oxygen saturation of 90%. So I like to kind of go through when I answer a question, I like to go through and kind of ponder possibly, like kind of hold on to some, but I like to look at all the answers first when I'm practicing. So oxygen saturation 90%. Well, I know ARDS has a lot to do with oxygen, and there's that refractory hypoxemia. So that sounds good, but I don't know if that's early. Respiratory rate, 24 breaths per minute. Well, that sounds kind of right. I know that they breathe fast, especially in the beginning. So, I mean, that sounds like distress. So that's a potential. Client has an audible friction rub. So friction rub, while that is related to, it can be related to the lungs, I don't think it's necessarily related to ARDS, or at least it might not be specific. A client could have a condition that has a friction rub and also have ARDS. But, when we're thinking of hallmark symptoms, we want to think of something. When we think of it, like the immediate thing we think after is it's this disease. Like there's those hallmark or signs, like if they have this, that this is the disease process. If they have this symptom, then this is the disease process they most likely have. That one doesn't stand out to me, but I'm not going to rule it out yet. I want to look at all choices. And then stridor present in the upper airway is the last choice. And when I think stridor, I think a closed airway. But when I think ARDS, I think wet, I think fluid. So I'm going to go ahead and cross that one out because I don't think it is. And ARDS is more of a lower airway problem, not an upper. The other thing I have to consider is early signs are generally less serious. So sometimes if I'm looking at an early sign, not always, because some people are already sick in the early phases, but sometimes when you're looking at early signs, a lot of times they're the less serious signs or the less deadly ones, because most illnesses, they don't start out deadly, but some do. But, most of them, they start out like the early signs are less dangerous than those late signs. So, so far to me, like if I had to narrow it down, I would get down to A and B. And then this would either come down if I have the knowledge of what is the earliest sign, or again, I try to think about, if someone was having a respiratory problem, what would be early signs they were having a problem? Maybe an early sign if, just thinking practically from my knowledge about, respiratory problems, if I'm having trouble breathing, the first thing my body starts to do is compensate and start breathing faster. So I think B is the correct answer, and it just happens to be. Something to know about ARDS, just to review some knowledge, is that when they first start out and have symptoms, their early signs are going to be an increased respiratory rate, a restlessness, irritability are the early signs. So they start out in a respiratory alkalosis, and then as the disease progresses, they go into a respiratory acidosis. So yeah, all right. So question 2. A nurse is caring for a mechanically ventilated client. Upon performing their initial assessment, the ventilator starts beeping with the words high pressure alarm across the screen. Which of the following initial actions is most appropriate for the nurse to take? So the key things here is that I'm assessing the client and there's alarm going off, high pressure alarm. So really this question's asking me, do I know what a high pressure alarm is? And then not just what it is, but what am I going to do about it? And it doesn't just say like, what am I going to do about it? It says initial action. So when you see the words initial, you want to think about what's the priority or what should I do first? So it's saying first, I have a high pressure alarm. Do I check the patient's oxygen saturation? Well, I mean, that seems to make sense. If there's an alarm going off, I want to see how they're tolerating it. But I don't know if it's the first thing that I would do. If someone has an alarm going off, I would think I would want to take action first to fix it versus assess first. We always try to think in that mind, like if someone has a problem, do they have time where we can assess them first, or do we need to go ahead and take action? Because another great way to look at this question too is saying, which one of these things is actually going to most directly help me? If I check the patient's oxygen saturation, is it going to change the fact that they have a high pressure alarm? Probably not. Just checking their oxygen saturation may tell me, hey, oh crap, yeah, they're not saturating well, but it's not actually going to fix the fact that they have this alarm going off. So really what I'm looking for in an answer here is something that's going to help me fix this alarm. The second one is assess for level of consciousness and for agitation in the client. So this one's another assessment, but I have to think about what is a high pressure alarm and what can cause it. So if a patient's agitated, that can create resistance, which could create high pressure. So I'm going to kind of hold on to that one and see what the other choices are. The next one says increase the FiO2 to 100% on the ventilator. Okay, well, I like that. That gives them more oxygen. And if they're struggling with something, that might help them. But then I have to go back to my initial thought too. Okay, is it going to fix the problem, or is it just, sometimes we might do things to support the patient along the way. But you'd have to have some idea of what a high pressure alarm is. High pressure alarms are usually caused by like kinks or other things in the tube. So if I had a kink in my tube or some sort of resistance, no matter how much oxygen I place on that, if there's literally resistance or something blocking the tube like secretions, no amount of oxygen can like push past that. So it's not necessarily solving the problem, it's just kind of masking the problem. So turning them to 100% probably wouldn't really help in the long run. When it comes to high pressure and low pressure alarms, we really have to get to the root cause in order to help them along the way. The next one says sit the client's head of bed up to 90 degrees. So this kind of goes back to the last one where like I could sit their head of bed up, but sitting it up is not necessarily going to change the cause of get to the root cause of their alarm. So then I would have to kind of, go into my, my mind bank about what I remember about high pressure alarms. And just as a reminder, high pressure alarms, you always want to think about where there could be an obstruction, a kink, or resistance in either the tubing, in the patient, like in their mental status, agitation, how awake they are, or in their lungs, where there might be like stiff, rigid lungs. So I need to get to the bottom of the cause, because a high pressure alarm is not going to clear itself. And again, it's not about the alarm not sounding. It's because when that's sounding, that's telling me that the ventilator is not able to do its job because there's something blocking it. And so my priority there is going to be to make sure the patient's getting ventilated well. So when it comes down to it at the end of the day, what we really want to focus on here is what is going to relieve the obstruction or help. Checking the patient's oxygen saturation is not going to relieve any sort of obstruction. Increasing their FiO2 to 100% is not going to relieve an obstruction. Sitting the client's head of bed up to 90 degrees is not going to relieve an obstruction. But if I assess for level of consciousness and for agitation in the client, it's possible if I assess for that and then find agitation that I could take action. Now, I know some of you are going to hate this question because you're like, but yeah, assessing for it doesn't change that they have it. But if I can assess and find the root cause of the problem, then I can start to take action. So out of these choices, the best option would be B, because all the other options don't really address getting to the bottom of the root cause of the problem. All right, hopefully that makes sense. All right, so a nurse is caring for a client who's mechanically ventilated. Which of the following actions is appropriate for the nurse to complete for this client? Select all that apply, your guy's favorite. So we could like to do these as true, false, and go straight down. And most select all that applies are knowledge questions. So they're looking for my knowledge of how like tasks to complete and other things. It could say what's appropriate, not appropriate. Most of the time they're not priority questions. It's possible they can be, but most of the time they are just straight up knowledge questions. So let's go down and see what we know about care for a mechanically ventilated patient. So choice A, is it my job as a nurse to maintain the client on a continuous pulse oximeter. So when I'm looking at what's appropriate, I want to think about what's going to be helpful for a patient. And also, because sometimes they can have stuff on here that's more general, and students really struggle with the general ones because they're like, well, shouldn't all patients be kept on a continuous pulse ox? Not necessarily, but I'll give you like let's say it said, hey, get 8 hours of sleep at night. Some people may struggle with that one because they're like, man, that's something you do for everybody. But you want to consider, sometimes I even ask myself the question, if I did this, would it cause harm to the patient? Or would it waste their time and it's completely unnecessary? So would keeping a patient on a continuous pulse ox help this patient? Yes. They're mechanically ventilated. I need to watch their oxygenation. Would it cause harm to keep it on? Nope. I would go ahead and say yes for this one. Suction the client every 2 hours while awake. So I know I want to suction them, and this is where sadness can sometimes get you, because sometimes part of the answer is correct, but the whole answer is not correct. So I like the suction part, but I don't know about doing it every 2 hours while awake. And maybe, I'm not sure if all intubated patients or mechanically ventilated patients are going to be awake. So that would be kind of hard to measure, but I'm not going to get too much reading into everything and making a story. The big thing I want to sit here is it necessary to suction a mechanically ventilated client every 2 hours? And I'm going to say no, because I think that we suction them, when there is a need or necessity for, like they have coarse lung sounds, or if they're having difficulty breathing, or maybe there's a sign of high pressure, and I think there might be an obstruction in the tube from their secretions. So usually I suction not necessarily because it's time, but because there's an actual need for it. So I'm going to say no to that one. Check the ventilator settings throughout the shift. Is that my role as the nurse? I think it is. I need to know what the patient's on. It's not necessarily that I can change them, but I need to know, just like I need to know, what it's kind of like an order for a patient. Like that's one of the orders. So I need to make sure that the orders are being carried out appropriately, and how much settings they're on. Because one of my roles as a nurse taking care of a mechanically ventilated client is getting them off it as soon as possible. So I need to know what settings they're on and if they're changing, so I can assess how the patient's doing and what direction we're going in their plan of care. So I'm going to say yes. So far I have A and C. D says ensure there's emergency equipment at the bedside. Well, since they have an airway, I would think that this would be needed, because if for some reason we do have to, do anything, like if we talked about in the last question, alarm goes off, what do you call it? Let's say that I'm trying to figure out what the cause of the alarm is. I'm not going to sit there and troubleshoot for 20 minutes or even, a couple minutes. If I cannot immediately figure out what action I need to take for a patient that has an alarm going off on their ventilator, I'm going to disconnect the ventilator, attach them to a bag valve mask, and start giving them breaths with that bag valve mask. That's it, right? Bag valve. Yeah, I think I said, if I'm saying it backwards or strange, what do you call it? It's like it's effectively like an ambu, what we call an ambu bag. It's a bag that helps to pretty much, I can give like 100% oxygen with it, and I squeeze the bag, and instead of having the ventilator attached to them. So if I'm ever concerned there's something wrong or not working with the ventilator, the first thing I want to do is detach them and start bagging them. So if that was an answer choice on the last one, that would have been the correct choice there. Because I don't want to, mess around and try to figure out a million things that are going on with the patient, because there's a lot of possible causes of alarms. If I cannot figure it out pretty quickly, then I need to make sure the patient is being ventilated and oxygenated appropriately. So that's when I'll use that ambu bag. So I do think that we want to have emergency equipment like an ambu bag at the bedside. And then E says assess for appropriate sedation levels and titrate sedatives. Well, that seems appropriate. It's my job as the nurse to assess and manage medication. So I do think that's appropriate. So I think it's everything except for B. And I'm correct. Woohoo! It's amazing how I know the answers after I wrote these questions. So a couple key things, because a lot of students ask, like, I just don't know what to study for mechanical vents. And, I do not know what's on your test, and I can only speculate. But, things that you could be tested over. You could be tested over or ask questions about the role of the nurse in mechanically ventilated patients. You could be asked about what to do, what the nurse's role is during intubation, how we're going to know the tube is in the right place, how to respond to alarms on the ventilator, understand the basics about settings and basic changes that might need to be made based on your ABGs. You could be asked questions about how to prevent complications when they're on the ventilator. You could be asked questions about weaning or taking someone, weaning someone off the ventilator and what process is involved with that. So that's just a few things, but most of it is around the daily nursing care, preventing complications, and managing that patient. Just kind of day-to-day management, how we address emergencies, and then how we just handle day-to-day how things are going. So it'd just be knowing things that can come up with a mechanically ventilated client, kind of the sticking the tube in, pulling it out process, what the role of the nurse is there, and other things that can come up, with complications when it comes to the ventilators. Pretty much what happens when they're doing okay and what happens when they're not doing okay as well. So hopefully that clears things up a little bit or gets you thinking more about some potential questions. So number 4, a nurse is caring for a client on a mechanical ventilator in acute respiratory distress syndrome. The physician has placed a prescription for neuromuscular blockade continuous infusion to assist the client in their respiratory efforts. What intervention must the nurse complete first prior to starting this infusion? So I have a patient that is on a vent in ARDS, and they've placed a prescription for a neuromuscular blockade. And if you don't know what that is a paralytic. And it's supposed to help them. It's saying, what do I need to do before I start a paralytic? So I would have to know what a paralytic does in order to answer this question. So the first choice is start a continuous sedative drip. So this is one of those things that I have to think about, like, okay, how would starting this help them with their paralytic? Well, if I'm on a sedative, it's going to help to keep me relaxed and chill and help to me with any pain or other needs while I'm medically paralyzed. So that sounds pretty good, but let me keep going. It says check the client's deep tendon reflexes. I know I check a train of 4 to see their muscular response or see how many twitches they have, but I don't know anything about deep tendon reflexes being related to a paralytic, because I don't think we need to check reflexes to know, if the deep tendon reflexes to see, because that would be like, like hitting the elbow or hitting the knee. What do you call it? Looking for that kind of reflex. I don't think that is related. So place the client in the prone position. So I know we use the prone position for ARDS, and if I read this question really quickly, I may choose that option because I'm like, hey, I know we use prone for ARDS, but you have to see what the question's asking you. It's saying, do I need to put the patient in a prone position before I start a paralytic? And I don't think they have to be in a prone position for a paralytic to be started. Now, does this patient ARDS maybe need to be in the prone position? Maybe, but that's not the question's asking me. The last one, check their most recent electrolyte levels. So this would come down for me to A and D. Do I need to check electrolytes before starting this, or do I need to start them on a sedative? And so this would also take me understanding that with any time you put on a paralytic, you always need to sedate them first, because it's very mean. Imagine being medically paralyzed. You cannot move, but you can feel everything, but you can't talk. Like you can't do anything, but your muscles are completely paralyzed, but you can feel everything, hear everything, experience everything. It's a very scary thing, and we never paralyze someone without sedating them first. There's that one. And let's say you get down to those 2 and you didn't have that knowledge, then you would have to use your best judgment here and kind of think about, which of these answers seems most related to ARDS and this kind of case, or go with your gut. All right, so question 5. Which client is most at risk for developing a pulmonary embolism? So when you do at-risk questions, what you need to do is you need to actually count the physical number of risk factors that a patient has and see who has the most. So the first one, I'm looking at age. Now, is age a risk factor for pulmonary embolism? And to my knowledge, it's not. They have diabetes and they have high cholesterol. Now, diabetes and high cholesterol can lead to blood vessel issues, but I don't know about it specifically leading to clotting issues, like where you're actually more likely to form a clot. So I don't think that person has any risk factors there, any major risk factors at least. A 45-year-old client who has a right pleural chest tube and recent chest trauma. This patient has lung issues. So a lot of times you might look at this and be like, oh, they got lung issues. So that might put them at risk for pulmonary embolism. But I have to remember a lot of the, that kind of that cascade that causes you to form clots. And it's like if you're still immobile, like, not moving around a lot, if your blood is super thick, or if you're like hypercoagulable and what do you call it now, like hormonal and stuff like that. And then if you are very like dehydrated, like there's a lot of different pieces that can possibly come together here. Now, the key here is not to create a story and be like, oh, recent chest trauma, they must have lost blood, they're at risk. Because I don't really know. All I know is I just have to say, does just having a chest trauma alone put someone at risk for pulmonary embolism? Maybe, but at most this person would maybe have one risk factor, and having a chest tube doesn't necessarily put you at risk for a pulmonary embolism. A 68-year-old client with COPD and hypertension. So I know COPD doesn't have anything to do with pulmonary embolisms. And even though hypertension is in the blood vessels and causes rigid blood vessels, I don't think that is a substantial or any risk factor, direct risk factor. So the last one is a 35-year-old client who just had a femur fracture repair and is a smoker. So I know for sure smokers are more at risk. That's one. And then if they just had a femur fracture repair, they've had a bone surgery. And when people have had bone surgery, especially hip or femur, they are higher risk for throwing a clot, and which could become a pulmonary embolism. So out of all these patients, B maybe has like one risk factor, or is like maybe the second most at risk, but the only one that has two risk factors is going to be D. So I'd probably get down between B and D, and then D has more risk factors than B does. So I would choose D as my final answer, and that is correct. So in other words, let's say that some of these other answers, they all had one risk factor, but let's say they had one that was really big. Like let's say the first one said, a 17-year-old client with diabetes that was on birth control. So even though they have birth control, which is considered a big risk factor for blood clot, they only have one risk factor compared to D, who has two. So you always just count the risk factors and whoever has the most. A nurse is caring for a client on a mechanical ventilator. The physician recently increased the client's PEEP from 5 to 10 centimeters of water. What assessment finding indicates that the client is experiencing a complication from this change? So like I said, questions that might be asked about mechanical ventilators may be related to complications or things that can come up with routine care of the ventilator. So if I remember back, so it's saying I'm increasing PEEP. So I have to think about, what's going to happen if I turn my PEEP up. So let's look at this. So the first answer choice says that the client's oxygen saturation increased from 90 to 95. Well, that doesn't really seem like a complication. I actually like that. I think that's good. And, I think that's what the PEEP is supposed to do. So this answer choice is probably in here because they're trying to make sure that I'm reading the question carefully. And it's not saying that which finding indicates that this is working or what is expected for this. It's saying what are showing that they're experiencing a complication. So A would probably show that it's actually working. The second one, client's respiratory rate decreased from 18 to 14 breaths per minute. So it is a decrease, and some people may be scared by that decrease, but a normal respiratory rate is anywhere like 12 to 20. So the respiratory rate's still normal. So, it doesn't really seem like a complication. And it seems like if they were breathing a little faster and start breathing a little slower, it's not anywhere in danger territory. They might be more relaxed. It's a good thing. It's not necessarily like we don't sit there and worry if someone started breathing just a few breaths less. Now, if they were breathing 3 times a minute, or that's an uneven number, but I guess anyone can breathe 3 times a minute. All right, I'm losing my mind. It's too late at night for me to be doing this, but let me just say I'll say 4 breaths per minute just to make an even number. So if someone was breathing 4 breaths per minute, then I would be concerned, but 14, I'm not so worried. So I'll keep it on the back burner, but right now I'm not that concerned about that. Client has increased oral secretions and needs more frequent suctioning. So then I have to sit there and be like, would PEEP change that? And if so, is that concerning at all? So like they're having more increased oral secretions. I don't think PEEP can cause that. And I guess getting secretions up is a good thing, because they're getting stuff, they're getting out some of their secretions and stuff like that. It's better out than to get stuck in their airway. So, but needing more frequent suctioning isn't necessarily always a bad thing. And if we're utilizing it correctly, of course. And I don't, at the end of the day, I don't think increased oral secretions is related to PEEP. So the last one is client's blood pressure went from 112/78 to 98/66 milligrams of mercury. So this is the only C and D sound like abnormal things. So I'd probably cross out A and B because both of those seem normal or maybe expected, like especially like maybe a patient was breathing faster at 18 because they were in distress. And now that I've turned up their PEEP, their oxygenation, it helps with oxygenation, then maybe they're breathing better. So A and B, and I know 18 is not fast, like they're breathing crazy, but you know what I'm saying is that, maybe they're just chilling. But anyway, A and B are normal. Or they're pretty in the normal range. The only ones that are abnormal are C and D, and I'm looking for complications. So I really have to ask myself, let's say I had no knowledge of PEEP. I have to really ask myself, is C or D more scary? Like, am I worried about more oral secretions or am I worried about a decrease in blood pressure? And, just based on ABCs, I'd be more worried about a decrease in blood pressure. So D seems like the best answer here. And it's the correct answer, just in case you're wondering. But if I did have knowledge of PEEP, I would remember that with PEEP, what happens is that their lungs, like normally the lungs open and then close, open and then close. But with PEEP, they open and then they open more, and eventually they're always open like this. So they never deflate. They're always open. And so if they're open like this all the time, that's a constant pressure on my my great heart vessels, like my vena cava, bringing heart back to my blood back to my heart. So if my lungs are always, if my lungs are never collapsing and resting and always putting pressure on my vena cava, I can have decreased blood pressure. So the best answer here is going to be D. A nurse is completing an assessment for a client who has had a recent chest wall trauma. Which finding would lead the nurse to call the physician? So for a question like this, it's saying that, hey, I'm doing an assessment and they've had like a chest wall trauma, something like that. And when do I need to call the doctor? So it's pretty much, this would require me to have studied what is normal or what is expected and when is the time to call the doctor. So with A, it says client states it is hard to take a deep breath. Well, I mean, I really would like them to take a deep breath, but I have to think about the other question I could ask myself is, which of these, if I don't call the physician right now, the patient is likely to die? Now, if they can't take a deep breath, that sounds uncomfortable, maybe painful, but doesn't sound like they're about to die. Second choice, client has a blood pressure of 103/68. So it's a little on the low side. But I don't know necessarily that they're about to die if they have a blood pressure of that. So let's keep looking and see if there's any better answer choices. Client has paradoxical chest wall movement. So paradox is something that's opposite of what it's supposed to do. So that already to my head tells me that there's something that's maybe not right. So their chest wall movement, something is off. No, I don't like that. That sounds like it could be a problem. And, I'm generally in my head thinking of something called flailed chest, but I'm going to keep that one there. It's my top option so far. And then the last one says, client states my pain is 9 out of 10. I can't stand it. So you have to start thinking about what's normal. Someone has chest wall trauma, let's say, and it could be a lot of things. It could be car accident. It could be, a stabbing chest wound or sucking chest wound, whatever it might be. It's going to probably be hard to take a deep breath. They're probably going to have a lot of pain and feel like they can't stand it. They may have had blood loss or other fluid losses, and they could be in hypovolemic shock, or they could have or lower blood pressure. So they could have decreased pressure because if you calculate the map there, the map is good on that blood pressure and the systolic's above 100. So, I have to think out of all of these. So let's say that I went down because pain is very rarely a priority, and not being able to take a deep breath, again, maybe not the best thing, but not life or death right this minute. But let's say I got down to blood pressure or this paradoxical chest wall movement. If I don't report that blood pressure, is that patient going to die right now? Most likely not. But if I don't report that their chest is moving out of sync with itself, that's what we call a flail chest, and that can literally lead to respiratory collapse. So I would have to know what a paradoxical chest wall movement was or what the warning signs are. This is why I really recommend, and by the way, so C is the correct answer, but I would really recommend when you're studying, okay, here's what I'm going to expect. And remember, with complex patients, they're going to be sicker. So they're going to seem a lot worse. And it's sometimes hard to tell, okay, this patient's really sick. When do I call the doctor? But this is what you need to study. When is it okay? And when am I going to call the doctor? So the correct answer here is C. So So the last question, question 8, a nurse is caring for a client with a chest tube. Which finding would require intervention? A says, chest tube. So this is saying like, which of these is abnormal? So this is again, where with a chest tube or device, I want to study what's my role in the device. What is okay with this device, and when am I going to need to call? So A says client has serous fluid draining into the collection chamber. So it's a collection chamber, so it should be collecting fluid. So in serous color fluid, that sounds pretty normal for coming from a chest tube. So I like that one so far. Client has continuous bubbling in the water seal chamber. Now I know that there's something with bubbling, and there's problems with bubbling in certain chambers, because then I look at answer C, client has continuous bubbling in the suction chamber. So that already tells me if there's two that are very similar but just a little different. So a lot of times there's one of those that is correct. But let's look at the last one, because I don't know which one we're supposed to have bubbling in or not. So we'll go back. It says client has titling present in the water seal chamber. And I think titling is okay. That's just what happens with their breathing. So I think that one's okay. So I'm going to use my strategy, and I'm down to B and C. And so let's say that I just don't remember which one. So then I would have to do my best and do my best guess and try to remember which one it is. I always remember the order that it goes in. The collection is all the way to the right, the water seal is in the middle, and the suction's on the left. So I think you could say SWC or CSW, whatever way you want to look at it, if you want to think about it or remember it in your head. This would be maybe a good thing to draw on your note card. And so I always remember, collection chamber, I want fluid in the collection chamber. In the water seal chamber, they should not have continuous bubbling. They can have occasional bubbling, especially when we first put it in. But really all you should have in that water seal chamber is titling. And then in the suction chamber, they can have continuous bubbling. That's an indication that the suction is attached and working. Really there should be no bubbling, continuous bubbling, or sorry, I should say, let me say no bubbling, occasional bubbling, continuous bubbling is what's okay. So yeah. So the correct answer there, that what I need to intervene on would be B, because if there's continuous bubbling in the water sealed chamber, that's a sign that there might be an air leak. And how I handle an air leak is I go up to the patient, I start at the patient, and I make my way out to the tube, and I try to find where their obstruction is. First, I look at the patient's dressing and right around their connections of their tube and see if there's air leaking somewhere. And there's a clamp on it. And pretty much what I can do is I can clamp, I'll go down, I'll put the clamp down and clamp it every so many inches. And let's say I clamp it, a little bit away from the patient. And if I clamp it and then that bubbling stops, that shows me that the problem is somewhere between where I clamped it into the patient. So I'm looking for holes. I'm looking for things like connections that aren't complete, things like that, or problems in my dressing. But let's say that I get all the way, I've clamped all the way down my chest tube and there's still bubbling in the chamber. Then I want to look at if maybe my chamber is broken. And so I need to maybe replace my actual pleurovac. So yeah. All right. Well, that is it for this one. I will get the other topic, renal, up one here soon. Hope this helped. See you for the next one.